Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Sharvil Patel. Dr. Patel is a third-year internal medicine resident at Northeast Georgia Medical Center. He completed his undergraduate studies at the University of North Carolina at Chapel Hill and earned his medical degree from Edward Via College of Osteopathic Medicine in Spartanburg, South Carolina. In the upcoming academic year, Dr. Patel will serve as a chief resident at Broward Health in Florida. His research interests focus on preventative and structural cardiology with an emphasis on advancing early detection and interventional strategies to improve cardiovascular outcomes. Please join me in welcoming Dr. Patel.
Good afternoon, everyone. My name is Sharvil Patel. I'm a third-year internal medicine resident here. And today we'll be talking about left atrial appendage occlusion, its evolution, evidence, and its expanding role in the stroke prevention for atrial fibrillation. Starting off with disclosures, I have no financial relationships or conflicts of interest to disclose. This presentation is intended for educational purposes only and does not endorse or promote any specific device, manufacturer, or commercial product. So the objectives we'll be talking about today, describing the pathophysiologic rationale for left atrial appendage occlusion and the prevention of thromboembolic stroke and atrial fibrillation, recognize the indications and contraindications for left atrial appendage occlusion as an alternative to long-term anticoagulation. We're going to compare and contrast the current spectrum of left atrial appendage occlusion devices currently used in clinical practice. We're going to interpret key clinical trial data that supports the use of left atrial appendage closure devices in clinical practice, and also identify appropriate patient populations for left atrial appendage occlusion based on guideline recommendations and clinical risk profiles, and discuss ongoing challenges and future directions in left atrial appendage management. So I have 3 questions. I'm just going to read them out, and then we'll go through my presentation, and then we'll answer the questions at the end. So question 1, after Watchman device implantation, a common guideline for anticoagulation involves A, warfarin plus aspirin for 90 days, DAP for 9 months, followed by aspirin indefinitely, B, warfarin plus aspirin for 45 days, DAP for 6 months, and aspirin indefinitely, C, warfarin for 45 days, DAP for 9 months, or aspirin indefinitely, or D, warfarin for 60 days, DAP for 6 months, or aspirin indefinitely. Question 2, left atrial appendage occlusion is supported by what class of indication in current U.S. guidelines? Is it 1A, 2A, 2B, or 3? In question 3, in randomized controlled trials compared with warfarin, left atrial appendage occlusion was associated with what? Lower rates of ischemic strokes, lower rates of hemorrhagic strokes, higher rates of all-cause mortality, or higher rates of cardiovascular mortality. So what is the left atrial appendage? It's a finger-like extension that originates from the main body of the left atrium. It's formed in the 4th week of embryonic development as a remnant of the embryonic left atrium. It extends between the anterior and the lateral walls of the left atrium, and typically it lies inferior to the pulmonary artery, superior to the mitral valve, and anterior to the left pulmonary veins. The ligament of Marshall, which is part of the Coumadin ridge, which we'll talk about in the next slide, is a band-like tissue that lies in the left atrium in between the left superior pulmonary vein and the left atrial appendage, and it's often implicated in the initiation and maintenance of atrial fibrillation, particularly paroxysmal and permanent AFib. So it can serve as a trigger for arrhythmias, so I just kind of wanted to point out it is a target for catheter ablation because it can be helpful in controlling or eliminating AFib. And just a couple of structures that I want to point out. Here's the left atrial appendage. The phrenic nerve lies anterior to it, and the left circumflex artery, as you can see here, lies below it. So when undergoing procedures and everything, is kind of good to keep that in mind. as far as complications go. So this is an echocardiograph finding of the Coumadin ridge. Coumadin ridge is an atrial tissue that separates the entrance of the left superior pulmonary vein and the left atrial appendage. It's called the Coumadin ridge because it can be misdiagnosed as a thrombus. So people often treat it with Coumadin, and that's hence the name. As you can see here, it looks like a Q-tip. That's why they call it a Q-tip finding. The pulmonary vein lies right here, and then the left atrial appendage, the orifice opens up right here. It's usually better demonstrated on transesophageal echoes, but if you have a good acoustic window, you can see it on a TTE. So when we talk about left atrial appendage, a lot of people know about its thrombogenic effects. Not a lot of people talk about its non-thrombogenic roles. It's not a key tissue or kind of part of the body that is necessary for survival, but it does play key roles. 4 key roles are hormonal regulation, atrial arrhythmias. It can help with hemodynamics, and research has been shown that it can act as a stem cell reservoir. So breaking it down as far as neuroendocrine function, ANP is a potent diuretic, and it's a natriuretic hormone that plays a major part in salt fluid balance. It influences the RAS system, and it can alter lipid and glucose metabolism. So ANP and RAS interact, can lead to upregulation of beta cells, which can result in increased insulin levels and decreased glucose levels. So ANP and BNP are basically released when the left atrial appendage stretches. As far as hemodynamic impact, its unique shape and location allow it to act as a reservoir for blood. It can act as a decompression chamber when atrial pressures are high. And like I said, it helps regulate intravascular volume by releasing natriuretic peptides. It has shown to have arrhythmogenic impacts. This was studied in the BELIEF trial. The empiric left atrial appendage electrical isolation was kind of observed. So they did a trial randomizing 173 patients with long-standing persistent AFib to patients having left atrial appendage electric isolation with ablation versus standard ablation alone. So at 1-year follow-up, AFib recurrence was 2-fold higher in patients who did not undergo left atrial appendage electrical isolation. So it does have a arrhythmogenic impact. And then as far as regenerative role, preclinical studies have shown that the feasibility of using an extracellular matrix patch to fix appendage micrografts can, on the surface of infarcted hearts, can play a key role. So like I said, it's just preclinical studies, but they have kind of been studying that. So how does the left atrial appendage lead to thrombosis? So as we know, AFib leads to irregular, rapid heartbeats. This can cause blood to pool and stagnate, particularly in areas like the left atrial appendage. And in particular, the left atrial appendage has a lot of trabeculations, small finger-like structures that can create areas where the blood flow slows down, leading to blood stasis and clot formation. As far as endothelial damages, it can lead to increased expression of prothrombotic factors and decreased expression of antithrombotic factors. So as far as myocyte necrosis, myocyte hypertrophy, and extracellular matrix abnormal changes. As far as hypercoagulable states, can lead to prolonged plasmafibrin clot permeability, prolonged clot lysis time, decreased plasminogen activity, and increased thrombogenin generation. And this is just kind of a reiteration. As we all know, the Virchow's triad, everything kind of applies as far as the left atrial appendage in this scenario: abnormal blood flow, endocardial dysfunction, and altered hemostasis. So the morphology of the left atrial appendage varies drastically. It's highly variable. For now, there's 4 distinct major shapes. As you can see here, the chicken wing, the cactus, the windsock, and the cauliflower. The chicken wing is the most predominant, present in 48% of patients. There's many other morphologies, but these are the four most studied and the four most common. So, how does morphology play a role in stroke risk in left atrial appendage in patients with AFib? So there were numerous studies that were done. Wang and colleagues in 2010 did an observational multi-center trial looking at the key morphologies, and they saw that chicken wing morphology has lower stroke risk than others. Same with some other trials that are listed here. And to note, the cauliflower and the windsock morphologies did play a higher risk in stroke risk in patients with AFib. It's important also to know that there's research studies being done that are trying to see if the left atrial appendage morphology can help redefine stroke risk. As we know, especially in borderline CHA2DS2-VASc patients, this can pretty much give them a good indication whether or not to place a left atrial occlusion device or start them on anticoagulation. As far as imaging, pretty much the diagnostic gold standard is TEE to look at it, but you can also do a cardiac CT, and they both help in identifying the morphology. So like I said, this is just another breakdown. The traditional classification puts it into chicken wing, windsock, cactus, and cauliflower. In my personal opinion, I don't think the morphology has a lot to do with stroke risk. I think it's the amount of trabeculations that are present in the left atrial appendage, because that allows the blood to slow down and stay more stagnant and thrombose. Newer classifications, so they've actually broken down the chicken wing into acute bend, which is an angle less than 90 degrees, or no acute bend, which is greater than 90 degrees. They say that if the angle is less than 90 degrees in the chicken wing, it's lower risk, especially for ischemic stroke. So what do we know? We know that more than 90% of stroke-causing clots come from the heart, forming the left atrial appendage. And this was probably the first groundbreaking trial was done. It was a meta-analysis back in 1996. Blackshear and colleagues looked at patients' morphologies of patients, surgical or autopsy reviews of patients that had non-valvular atrial fibrillation. And they saw that the majority of the thrombi that were in this patient's existed in left atrial appendage, close to about 91%. And here you can see the rest of the trials that pretty much confirmed that percent of thrombi in the left atrial appendage was at or greater than 90%. It's important to note that if you have AFib related to mitral stenosis or a valvular cause, the thrombi could be in the body of the left atrium or the left atrial appendage. It's pretty much split 50-50. This is why left atrial appendage closure is not really indicated in valvular AFib, like rheumatic mitral stenosis, and that's where non-valvular AFib comes from. So we're primarily looking at patients with non-valvular atrial fibrillation. So what do we know? We know that oral anticoagulation works, but to what effect, right? AFib is a growing epidemic. Its projected prevalence is affecting more than 12 million individuals in the US by 2050. And roughly about 50% of patients with AFib that are at stroke risk are not receiving anticoagulation for various causes. We know that compliance with oral anticoagulation remains poor, and we know that poor compliance pretty much means no stroke protection. So research has shown that patients that are at stroke risk, that have AFib, that were on anticoagulation and then stopped it, they're at exponentially higher risk of having stroke off of it, pretty much the same compared to patients that are not on anticoagulation. And so what happens to these patients with contraindications to oral anticoagulation? And that's kind of where the field of left atrial appendage occlusion comes. We're trying to fill the unmet need of patients with atrial fibrillation that have contraindications, oral anticoagulation, and we know that pretty much closing it would be useful. So in most causes, how is the left atrial appendage occlusion device inserted? Basically, it's a femoral approach. You go in through the femoral vein up to your heart into the right atrium. And then in the right atrium, you stick a needle or radiofrequency catheter across the inner atrial septum, and then you implant into the left atrium around the appendage. So these are the 2019 ACC, AHA, ACC, PHRS guidelines. In 2019, the recommendation for percutaneous approach to occlude the left atrial appendage was 2B classification. And the recommendation was that percutaneous left atrial appendage occlusion may be considered in patients with AFib at increased risk of stroke who have contraindications to long-term anticoagulation. And this was kind of guided by the clinical trial data and FDA approval of the Watchman device. So now, as far as the newer guidelines in 2023, late 2023, early 2024, this changed to a 2A recommendation. This was in light of additional data and safety and efficacy of the left atrial appendage occlusion devices. And between these two guidelines, one trial emerged that kind of made the difference, and it was a PREG 17 trial, and we'll kind of talk about that later. But so the current recommendation is 2A, and the recommendation is in patients with AFib, a moderate to high risk of stroke, so CHA2DS2-VASc score greater than 2 or greater, and a contraindication to long-term oral anticoagulation due to a non-reversible cause, percutaneous left atrial appendage occlusion is reasonable. So here is a brief timeline on all the trials and all the devices that are present. This only goes up to 2020, but as you can see, the Plato device was the first device that percutaneously that was implanted in humans beginning of 2001. Since then, the device that we kind of know that's most common, the Watchman, was introduced in 2005. There's various existing trials that have gone on. The left atrial appendage occlusion study, initially that was done in early 2004, looked at CABG patients, and patients basically, what they did was patients undergoing triple bypass, quadruple bypass CABG surgery, they occluded the LA left atrial appendage using sutures or stapling devices. So this was kind of the first trial that showed that clipping the left atrial appendage could lead to decreased stroke risk. As we move on, you can see that the Implantser device, which we'll talk about, was introduced in 2008. The Lariat device, which we'll talk about, was introduced between 2008 and 2009. And one of the main critical trials as far as percutaneous left atrial appendage devices was a PROTECT AF trial and the PREVAIL trials, which we'll talk about in depth. They were around 2011, 2014. And know that the first original Watchman device was FDA approved in the US in 2015, late 2014. And something that's not mentioned here is that the amulet device, or the second generation of the Implantser cardiac plug, was actually approved, FDA approved in the US in August of 2021. And then what we know is that in 2019, the Watchman Flex, which is a newer version of the original Watchman, was FDA approved in 2019. So this is an extensive chart that just goes into all the devices that are currently out there. I'm not going to go through all of them. The main ones to kind of focus on are the Watchman device, which is manufactured by Boston Scientific, the Implantser devices, especially the amulet, which is manufactured by Abbott, formerly St. Jude Medical. And as you can see, the design is pretty much different in the main two ones we'll talk about. The Watchman is a single lobe, whereas the amulet devices and the Implantser devices are double. They have a lobe and a disc. And then you can see the various sizes that it can fit into left atrial appendage orifice. Again, this is just kind of a visual representation of all the devices. This is the most commonly one kind of we all know, the Watchman Flex. This is the ACP amulet or Abbott device that was first kind of discovered, and then this is a reiteration of it, the amulet device. Plato was the one we talked about, which was the first one ever implanted in humans. The Lambre is one that's up and coming as far as the wave crest also. And then the Lariat device, which is basically an epicardial and endovascular device, which we'll kind of talk about. So going over kind of key devices, this was a Plato device, first percutaneous left atrial appendage device implanted in humans in 2001. This was followed by the European Plato study, which evaluated safety and efficacy of the device in 180 patients with non-valvular AFib and contraindications to warfarin therapy. This trial had numerous complications, 2 deaths within 24 hours, 6 episodes of cardiac tamponade, and 1 device embolization. So follow-up was halted and the trial was prematurely discontinued because of financial issues. This is no longer commercially available. Just a few things to point out. This nitinol strut, it's basically a memory alloy shape, meaning it can expand and contract under certain conditions, and it allows the device to be delivered with a catheter and expand within the left atrial appendage, creating a secure seal. The second device, Watchman and the Watchman Flex 2.5. So the Watchman was first USA FDA approved back in 2015, and it's part of the Protect AF and the Prevail trials, which we'll talk about in depth. And the Watchman Flex was the next generation of the Watchman device, which was FDA approved in 2020. The differences between the two devices can be seen visually here. The Watchman 2.5 device only allows for partial recapture, while the Watchman Flex allows for full recapture and partial recapture. And that involves retracting the device partially into the access sheath or fully into the access sheath. As you can see, the Watchman 2.5 has a single row anchor, whereas the Watchman Flex has a dual row anchor. As far as the tip, the Watchman is open, the 2.5 is open versus the Flex, which is closed. And the strut flames are more as far as the Watchman Flex goes. And then the Watchman Flex can kind of encompass a broader size range of the left atrial appendage orifice, so allows for that. This is the implants or cardiac plug and the implants or amulet device. The length of the device is actually shorter than diameter, allowing it to be used in cases of shorter left atrial appendages. It has a dual seal mechanism, as you can see here, where there is a pretty much disc here at the neck, and then there's another kind of closure at the orifice of the appendage. Like I said, the implants or amulet device is the latest generation of the implants or cardiac plug, and it was FDA approved back in 2021. And it was part of a very extensive amulet investigational device exemption trial, which we'll kind of talk about, which compared the amulet to the Watchman device. And then the other device is the Lariat. So this is pretty interesting in the sense that it's a ligation system that's used, it basically combines epicardial and endocardial approaches. So as you can see here, what happens is that a magnetic wire is inserted into the heart through the femoral vein, and it's matched to another wire from the outside of the heart, usually through kind of a stick in the chest wall. And what happens is there's a magnetic field, a wire connection that attaches both, and it allows the suture to go over the left atrial appendage and tie it down. Eventually, what happens is over time, the left atrial appendage atrophies. And this was part of the AMAZE trial. And what's kind of interesting about this is you don't necessarily need oral anticoagulation after this procedure because the left atrial appendage is essentially no more. So I know this is an extensive chart, but this kind of a few things to point out here. As far as the mechanism, the Watchman and the amulet are both endocardial, meaning you have to go intravascularly. The lariat is both endocardial and epicardial. The access route, like I said, is transeptal in the Watchman and the amulet, and it's dual in the lariat. The lariat is not yet FDA approved. That's the biggest difference. It's only off-label use in the US. And the major trials we're going to talk about as far as the Watchman goes, the Protect AF and the Prevail, which are pretty much complementary trials. The Pinnacle Flex trial was basically a trial for the Watchman Flex, and we'll talk about that later as well. The success rate, as you can see, is pretty great in all three devices. And as far as peri-device leakage, or the amount of leakage that comes off of the plug, you can see is slightly higher in the amulet device. So these were the biggest two trials for left atrial appendage occlusion. Of note, there are only 3 published trials that have ever been done comparing percutaneous left atrial appendage devices versus DOACs in assessing for stroke risk. So the first one was the Protect AF trial. Its full name is a Watchman Left Atrial Appendage System for Embolic Protection in Patients with Atrial Fibrillation. Was first published in 2009, was a randomly controlled trial with a sample size of 707 patients. Underwent randomization, and the primary efficacy endpoints were a composite stroke, systemic embolism, and CV unexplained death. This efficacy result did meet non-inferiority versus warfarin. So the Watchman was non-inferior to warfarin in this trial. The U.S. Food FDA basically issued a non-approvable letter on the basis of this trial, saying that there were several issues to address as far as efficacy and safety, and that's where kind of the Prevail trial came, and it basically addressed the concerns that were in the Protect AF trial, and these 2 trials were pivotal in issuing FDA approval for the Watchman, the first Watchman device in 2015. So the Prevail trial was basically a prospective randomized evaluation of the Watchman left atrial appendage closure device in patients with atrial fibrillation versus long-term warfarin therapy. And it just kind of expanded on the Protect AF trial. So pretty much kind of the same indications they looked at, and then we'll kind of go into each one. So when we talk about the Protect AF and the Prevail trials, usually they're talked about complementary to each other, so both of the data is basically pulled for both trials. So when we look at 5-year outcomes as far as efficacy goes, you can see that as far as efficacy in general, it's pretty much comparable. As far as all stroke goes, it was right at the hazard ratio of 1. You got to dig a little deeper to kind of look at the difference. As far as the different types of stroke, as you can see here, with the Watchman device, ischemic stroke actually favored warfarin as far as ischemic stroke goes, but it was non-significant. Intuitively, hemorrhagic stroke favored the Watchman device, obviously. And if you look at kind of major bleed and major bleeding, non-procedure related complications, it pretty much kind of favored Watchman. So this was another study done called the PREG 17 trial. We know that the previous 2 trials were sponsored by the manufacturers of Watchman. This trial was non-industry sponsored, so it looked at both percutaneous, the amulet, and the Watchman devices. And instead of using warfarin, they compared DOACs. Primarily 95% of the DOACs were apixaban. So 402 high-risk AFib patients were randomized. And what you can see here, as far as the primary endpoint of stroke, TIA, systemic embolism, CV death, you can see that the percutaneous occlusion devices were non-inferior versus DOACs in meeting their primary endpoints. And if we look at the 4-year outcomes, it's pretty much the same. Watchman and amulet device remains non-inferior to DOACs when you look at preventing major cardiovascular factors, neurological or bleeding events. Furthermore, non-procedural bleeding was actually significantly reduced with the left atrial appendage occlusion device intuitively. And then another trial that kind of compared the two directly as far as amulet and Watchman was the amulet IDE trial done through 2016 to 2019. Was published in 2021. It was a prospective multi-center randomized controlled trial that looked for non-inferiority. So when we look at the results, you can see as far as a rate for the primary safety endpoint was 14.5% for the amulet occluder and 14.7% for the Watchman device. So it did meet non-inferiority as far as the amulet versus the Watchman in procedure-related complications, major bleeding, or all-cause death. And if we look at stroke or systemic embolism risk as the primary efficacy endpoint, it was actually dead even, 2.8% for both groups. And basically, this trial kind of helped support the FDA approval of the amulet in 2021. So if we look at left atrial appendage sealing, which was signified by residual jet greater than like 45 millimeters, what you can see is, as far as the amulet, if you look at 0 millimeters, basically means that there was no leak. 63% of the patients with the amulet device had no leak versus the Watchman, 46% for the Watchman device. If you look at leak up to 0 to 3 millimeters, you can see that the amulet actually had less of a leak from 0 to 3 millimeters, even up to 3 to 5 and greater than 5. And something to note here is that this trial for the amulet was compared to the original Watchman 2.5. So the Watchman Flex design has improved safety and sealing, but was not included in this trial. And then if you look at the 5-year outcomes of the amulet IDE trial, basically the key findings for this are that there's low and similar clinical outcomes through 5 years between both devices. Not much has changed as far as ischemic stroke, systemic embolism, major bleeding, CV death, or all-cause death. But what you can see in the slide right here is that as far as complications, the number of device-related thrombus, impaired device leakage was actually more in Watchman device compared to the amulet device. And then as far as kind of breaking down stroke, there was more fatal or disabling strokes through 5 years for the Watchman device as compared to the amulet recorder device. So those were the kind of the 3 main trials that were published. There's ongoing research related to other studies that are there's numerous other trials that are being studied right now that are ongoing. So if you look at the indication for high risk of ischemic stroke down here, this is basically taking into indication left atrial appendage occlusion devices on top of DOACs. So this can be observed through the ELAPSE trial and the left atrial appendage study 4 trial, which are still ongoing. In patients that have high risk of bleeding, and we're trying to avoid DOACs, these are the trials that are ongoing, the closure AF and the stroke close. And then we're actually looking at trials at patients who don't have any contraindications for oral anticoagulation. There's 3 small randomized controlled trials that are going on that are called Champion AF, Catalyst, and Occlusion AF, and they're actually taking into account younger set of patients as well. So as far as complications, procedural complications, death is less than 0.2%, stroke less than 0.2%, whether it be ischemic or hemorrhagic. Systemic embolism is rare, pericardial tamponade is rare, device embolization is pretty rare, and then obviously you can have vascular complications when inserting the device and other numerous kind of other periprocedural complications. Post-procedural complications, the 2 I want to emphasize are peri-device leak and device-related thrombus, because this is an ongoing debate in the left atrial appendage occlusion device realm. If you look at peri-device leaks, greater than 5 millimeters on TEE, only 1 to 3% of devices have it. Greater than 3 millimeters on TEE, 10 to 25%. And device-related thrombus, which is basically a thrombus forming after the device after implantation, is pretty much 3 to 5%, which I think is a pretty significant amount in this kind of patient population. So device-related thrombus happens in 2 to 4% within 1 year after placement of the device. What we know is that has a 2 to 4-fold increase in stroke risk, and we'll kind of talk about that further. But independent predictors of thrombus have to do with age. As far as higher age, it indicates more of a chance of having a device-related thrombosis. If you're female, having permanent atrial fibrillation, LV dysfunction, a higher CHA2DS2-VASc score, coagulopathy, and renal disease. They do have certain classifications for device-related thrombus, which we won't get into because it's quite extensive, but just know that there are classifications to judge how severe the thrombus is. And the prevention, it's basically just restart them on anticoagulation and frequent surveillance. And this is a topic that has been highly debated in many aspects. I would say this is probably the most feared complication because it intends to do the very thing we're trying to prevent, which is stroke. So the incidence and timing of drug-related thrombus is something interesting to look at. If you look at the PROTECT AF and the PREVAIL trial, the incidence of the thrombosis was 3.7% at 12-month follow-up. The Amulet IDE trial, the incidence of thrombosis was 3.4% for the Watchman and 4.8% for the Amulet at 18-month follow-up. What we know is that late occurrence and unpredictable timing of this device-related thrombus has been a major concern. That's why, so there is a rationale for short 45-day antithrombotic regimen after placement of the device with the Watchman. It's to prevent the drug-related thrombosis from happening and to allow for adequate endothelialization. Another interesting thing was that in the Amulet IDE trial, in the Amulet arm, a majority of these thromboses occurred early, less than 45 days, whereas in the Watchman arm, they occurred mostly after 45 days. So that just gives you an indication of, as far as surveillance, do we need to be looking at the Watchman devices more closely after 45 days as compared to the Amulet devices. Another complication is peri-device leakage, which has been a hot topic in this field. If you look at the mechanism of leak with the plug occluders, which is a Watchman device, you can have an edge leak. You're not going to have 100% seal in any of these devices, but you can also have an uncovered lobe. So if the appendage has multiple lobes, you're more prone to having peri-device leakage. And then uncovered proximal tissue, and also fabric leak, which I would say is the rarest complication. That pretty much never happens. And if you look at it with the lobe and the disc occluders, which is the Amulet device, pretty much the same thing. So what do we know about peri-device leakage? It is linked to ischemic events. Initially, they thought that any leak less than 5 millimeters was nothing to worry about. We could stop anticoagulation. If you kind of look at the trials as far as the Amulet IDE, in the red is patients that had peri-device leakage, in the blue is patients that didn't. And as you can see in each trial, the Amulet IDE trial, even the Watchman trials, the risk of ischemic events was higher in patients that had any type of peri-device leakage at 45 days or 1 year. So does the degree of peri-device leakage matter? Like I said, there is greater risk of having stroke if the device leakage is greater than 5 millimeters, but multiple studies have shown that even if the leak is less than 5 millimeters, you're still at increased risk of stroke, whereas compared to those patients that have no leak at all. What you can see here is a rendition that this study was basically done in patients that had a leak of less than 5 millimeters, so a leak of greater than 0 but less than 5. And you can see that these patients had greater non-disabling strokes, greater CV death. So it does play a key role. And the guidelines are ever changing. Before, it used to be that any device, they thought 3 millimeter leak or more was higher risk of stroke. They moved it to 5, but newer studies are coming out that says that any type of leakage is kind of a concern. So as far as antithrombotic therapy, this is also a heavily contested topic in this field. What we know is that as far as the original protocol for the original Watchman device, you were expected to place the patient on warfarin or aspirin for 45 days to allow for that endothelialization and decrease the risk of device-related thrombosis. After 45 days, you do surveillance imaging with TEE, and you assess the risk of peri-device leakage. Based on the original Watchman, if it's less than 5 millimeters, you can initiate DAP treatment, usually aspirin and Plavix. And then after 6 months, if the surveillance imaging is still fine, no peri-device leakage or less than 5, you can just keep them on aspirin indefinitely. The Watchman Flex device came up with an updated protocol. Instead of warfarin and aspirin, you can put them on a DOAC and aspirin as for the first 0 to 45 days. If they have contraindications to antithrombotics, you can just start with DAPT initially for 0 to 45 days. And then 45 days to 6 months is pretty much the same regimen that you do in the first 45 days. Then around 6 months, if the peri-device leakage is low, then you can just start them on aspirin. As far as the amulet device, you necessarily do not need a DOAC or warfarin at all. You can just start them on DAPT, aspirin, and Plavix. And then after 6 months, aspirin alone. Now, this all varies based on different risk factors for each patient, but this is the pretty much standard kind of guideline you go by. So, like I said, clinical considerations to take into consideration, patient-specific factors. The choice of antithrombotic therapy should be considered in each individual because they have different individual risk factors. Imaging follow-up, so TEE is the typical gold standard that you kind of get around 45 days post-implementation to size for any related thrombus or peri-device leakage. And its findings may necessitate adjustment in your therapy. And then as far as long-term management, after the initial 6-month period, most patients can just transition to aspirin monotherapy alone. So what are the future insights? The next generation occluders are coming out. There's more data being done, more trials being done with improved sealing, reduced thrombogenicity, and then fully endothelialized surfaces. I think I want to see more head-to-head trials with the Watchman Flex, which is the newer generation of the Watchman device versus the amulet. And then just the standardization of post-procedural and device-related thrombosis surveillance protocols. There's really no set guideline on when to do surveillance and when to stop as far as anticoagulation if you need to. And then other key trials that are up and coming, the Champion AF, the Catalyst, and the Option trials. These will define left atrial appendage occlusion in moderate risk, younger patients, and in patients who don't have any contraindications to DOACs. So coming to the questions, question 1, after Watchman device implementation, a common guideline for anticoagulation involves what?
We're going B.
Correct, yes, B is the answer. Question 2, left atrial appendage closure device is supported by a class of what indication?
B.
E, there's no E.
No,
Oh.
B as in boy.
B as in boy, yes. So it is currently 2A, was changed in 2023 from 2019, which was originally 2B. And then question 3, in random RCTs compared with warfarin, left atrial appendage closure is associated with what?
Oh, hold on, we got to think about this one. B as in boy. We're going B as in boy.
Yes, yeah. So randomized controlled trials have shown that patients with left atrial appendage occlusion devices, there's less rate of hemorrhagic stroke. And then I want to thank Dr. Chandra, Dr. Gross, and Jackie for mentoring. These are my references.
Thank you, Dr. Patel. I'd like to remind you, if you're watching online and have a question, please enter it in the Q&A section and we'll ask for you. But in the room, do we have any questions or comments?
I'm sorry, can you, the Lariat, are they still being under studies or, okay? Because it looks like the best procedure, forget about the Watchman. And I think the people who make the Watchman and the Amulet and the other are gonna compete and probably don't want the Lariat to come out because it's the best of overall.
Right, yeah, and there are emerging trials on the Lariat. It is off-label use in the U.S., but it's not FDA approved. And one thing they're looking at is the diameter of the appendage. If it's like greater than 40 millimeters, they're saying, or research is showing that the Lariat could be a way to go because the previous devices don't have that width of diameter to cover.
It was a great presentation. Dr. Patel, I have a question. With the incidence of peri-device leak, and we're using TEE to get the anatomy, do you think going to MRI or CT would be better to reduce the incidence of the leak because you know the anatomy better?
So yeah, in real time, right now the gold standard is TEE, but they are looking, and it's always a hot topic in this field as well, whether we should be looking at CE or CT to look at the anatomy further. But as far as peri-device leakage right now, I think TEE is a better indication of peri-device leakage.
All right. Thank you, Dr. Patel.